And by definition, infertility is the inability to conceive within 12 months of regular coitus or within 6 months for those 35 years or older. That's just kind of by definition what infertility is. Second sentence. And then approximately 40% of infertility cases are due to female infertility issues. 40 is due to the male issues. And then 20% is either a combination of the two or just an unexplained, don't know why they're having an infertility issue. Alright, evaluating the cervix. The role of the cervix is fertility. Is to provide a non-hostile environment to harbor sperm. Cervix does this with the glands that secrete mucus and crypts that hold sperm. Ultrasound used to evaluate cervical length during pregnancy to assess for cervical incompetence, because you don't want your cervix to efface and to dilate before time. And sometimes this happens around 20 weeks. And the cervix becomes incompetent. And here is what a normal cervix will look like. It's harder to kind of be able to measure a cervix whenever there's not fluid in the endometrium. I mean, you guys know, because I would tell you guys to measure the cervix whenever you guys are getting in the lab, you probably wouldn't quite know where to stop. But here is the cervix. Here's our internal os here, and then our external os here. So all of this is cervix. And this is what it's supposed to look like. So this is where whoever this is going to start dilating when it's time for the baby to come. What? Okay, now I got one picture. Okay. Why is that measurement right there? Okay, so now this, in this image, I don't have my thingy, so the cervix is starting to dilate. This is supposed to be closed, right? Like on the last image. But now it's dilating, and they're measuring what is closed, like what's left before it's just completely open. And so that's an incompetent cervix. You see the baby head there. Here's a really, really bad incompetent cervix. So, see, remember, all of this is supposed to be closed. Right here, here's our internal os. All of this should be shut. You shouldn't have any of the membranes hanging out through the cervix there, or through the cervix. Okay. Evaluating the uterus. And lay down, Malia.
You got a next shot.
Alright, when evaluating the uterus of the infertility patient, the sonographer has two main objectives. The first is to assess structural anatomy. Going back to like week 1 and 2 when we talked about the unicornuate, bicornuate, septate, arcuate, all of that. Some of those congenital anomalies can cause infertility issues. And also to assess the endometrium. Assessing for the structural anatomy, again, that refers to the different types of congenital abnormalities. And also you want to check the echogenicity of the uterus, because there's a lot of fibroids in there that are, there's a submucosal fibroid that's pushing on the endometrium, preventing fertilization. And when evaluating the endometrium, you want to evaluate the thickness. And then echogenicity characteristics include evaluation for any intracavitary lesions. So that's those submucosal fibroids, endometrial polyps, anything inside there that can prevent fertilization and implantation. Okay, congenital uterine anomalies. This is just kind of going back over a few of them. Again, congenital uterine anomalies are the result of defects in the Müllerian duct development, because the female reproductive system forms from the Müllerian duct, right? Yes. And what's another name for the Müllerian duct? Let's go, guys. Oh, I'm so proud. Okay. All right, and then it's also associated with renal anomalies. Why is this?
Because they come from the same area.
And what's it called?
The cornuate. No.
You say that to the board? Is that what you're talking about? So it's because the urinary system and the reproductive system both form from the urogenital ridge of the embryo. Urogenital ridge. That's on the OBGYN registry. A few times, like you gotta know that. Alright. It'll ask you about the Müllerian duct, paramasonephric duct, and then also there'll be questions on there about renal anomalies. It may say, you know, urinary may be the answer. That would still be right, just because it's not renal. That was on a test last time I taught this, and someone X'd it out and was like, no, that's not right because it's renal. And it had urinary thing. I was like, no, same thing. Alright. Didelphys uterus. Does anyone remember what this is? I was wondering where these were.
Yeah.
They were on our bookshelf.
Oh.
I've looked everywhere for these. Except for, that's a week 6 homework. What happens to those things? Yes. So we have 2 uteruses, 2 cervixes, and 2 vaginas. This has a low infertility rate. Alright, and then the bicornuate uterus. What is that one?
Duplication, but not of the cervix.
Okay, what else?
Wide.
Yes, a wide-spaced cavity, and then there's a fundal notch. Instead of just having like one fundus, it's like you got 2 and there's a little fundal notch. Looks like a little heart. And then you get the wide-spaced cavity. And it also has a low rate of infertility. In the septate uterus, what is that? That's right, and they have closely spaced cavities. And that actually, a septate uterus, that congenital anomaly actually has the highest rate of infertility. Because if implantation occurs on that septum, it won't be able to sustain the pregnancy. It won't have enough like blood supply and stuff to it. Alright, the T-shaped uterus, what is this?
Comes from that girl I got over there.
VES, I can't say it either. Where is it? Oh, diethylstilbestrol. Oh, that sounds pretty good, actually. Diethylstilbestrol. VES, if the mother took VES while she was pregnant with that little baby girl, the baby girl may be born with a T-shaped uterus or the arcuate uterus. Okay. What? Oh, yeah.
Yeah, when they start taking it, it's a certain year.
Yeah, I should see it. Gosh, I've actually never seen it. Alright, evaluating the endometrium. Thickness encompasses, so this is talking about the measurement. It encompasses the thickness of both the anterior and posterior endometrial layers and sagittal plane. That's how we measure the endometrium. And this is our uterus. And then we've got this endometrium here. And all this endometrium. You know, it's 2 layers actually. You've got the cavity that goes up the center that actually would expand with fluid. You measure both of these. You're going to measure the anterior and the posterior. And try to measure it up here, like towards the fundus. So this is usually where it's going to be thicker. Like, don't measure your endometrium down here. Alright? What is it, Dave?
I was thinking out loud.
What about Victoria's Secret?
No, I ordered some stuff over the weekend. No, it's not no underwear. It's some pink stuff. It's not no
Oh, yeah. You're not listening.
It's clothes. It's not no. Yeah.
Okay.
But you're not listening to me?
I am.
We
It's
know how to
just
measure
a
the
thought.
endometrium.
It's on the board in there, how to measure the endometrium.
I know, but I'm still getting the endometrium measured wrong.
Oh.
I'm with her.
She said she don't measure hers wrong.
Yeah, measure it up
Measure
here.
mine wrong.
Don't measure it down here like near the cervix.
Oh, so weird.
Yeah, I don't have much of one either.
I'm sorry. That's definitely.
Okay, And then in the first half of the menstrual cycle, this is just kind of going over what the endometrium looks like again. So this is like half of the OBGYN ministry here. Is what is about what the endometrium and the ovaries look like during the different phases. All right. In the first half of the menstrual cycle, the mucosa begins to proliferate because of increasing estrogen levels. So the endometrium starts to get thicker because you have your menses, get all that out, and then it starts from nothing. Pretty much, you just have a little thin echogenic line, and it starts to thicken. And once we get to the proliferative phase, we end up with 3 line signs. And then ovulation occurs on approximately what day? 14. And then what phase comes after the proliferative phase? And the endometrium. Secretory. Luteal is with the ovaries.
What chapter is all
It's in a lot of them. Quite a few of them.
I want like a list of all of them, just like in order.
It's 39, I think. It's a good one.
Yeah, you need, I need like a chart.
Yeah.
This says first, and this is what it does.
Yeah.
I have it
Yeah,
on my phone.
There's like a picture on one page.
I wrote it out really nicely on PowerPoint.
Actually, the cartoon.
On chapter 39.
Yeah, 960, chapter 39, it goes over the endometrial changes and also the ovarian one. So, but the PowerPoint, I made it all nice and pretty. Okay, so that's a 3 line sign, and here is 3 line sign. Here's our proliferative phase.
I've never seen this.
You've never seen that? Well, not in this class, because your class.
What she thinks her class crazy.
I don't know what is wrong with your class.
But then Ms. McCullough said something about if you want birth control, you won't see
That's
it.
a stimulate hormone, she said.
Yeah, we've been putting, there is no hormone, no
She
female
said if you're on birth
hormone.
control, you're supposed to check that box.
Oh, yeah, and your, if you have an IUD too, because it admits.
Yeah, well, we failed. We didn't know that.
We've been saying it ain't none of us hormone.
We
all got, and you get no nutrients, but we.
That's why y'all don't need it, because you're on birth control. I'm not, I don't need to be.
Well,
Okay.
if it's small, that means they probably are. When you're on the birth control, it's microscopic.
Because your endometrium's not gonna proliferate, because it's like it's making your body think you're pregnant.
And it gets bigger and stuff when it goes through the little face thing, but I don't know.
All right, so after ovulation, progesterone secreted by the corpus luteum. It is secreted by the corpus luteum. And then secretion of the progesterone begins the secretory phase of the endometrial cycle. So after the proliferative phase, you have the secretory phase. And this is the endometrial cycle. Whenever it's the ovaries, what are the cycles?
It is follicular, then ovulation.
Uh-huh. Is that on your phone?
Maybe.
Okay, well, that's right.
Yeah.
Alright. So during the secretory phase, the endometrium becomes thickened and very echogenic as a result of stromal edema. There is loss of that triple line sign, or the 3 line sign. So then you just have like the thickened endometrium. I know, that's a little hyperplastic there.
I don't know what that would look like. Jeez.
I look like that.
Well, when it's in a certain phase.
Mine's look like that the whole time.
There's something wrong.
Hers don't ever.
there's a senior who says that too, but seriously. Okay. Alright, the thickness of at least 6 millimeters appears to represent central threshold for achieving pregnancy. So if your endometrium stays super thin all the time, then that's going to cause an infertility issue. So you want the endometrium to measure at least 6 millimeters for it to be like a good implantation site. If not enough progesterone is produced in the luteal phase, endometrial lining may be thinner than expected on ultrasound evaluation. I've actually had this happen to a friend of mine. They tried for like 2 years. She finally went to the doctor, said her progesterone was low. She took 1 progesterone pill, got pregnant. So, or took it the next time around, whatever next time her ovulation was supposed to happen, and got pregnant right away. So she just had low progesterone. And then if you have a lack of progesterone production, that's known as the luteal phase deficiency, because it happens. During the luteal phase, even though it correlates to the secretory phase, it's because there's not enough progesterone, and progesterone is secreted by the corpus luteum, which is on the ovary. That's why it's luteal phase deficiency and not secretory phase deficiency.
Yeah, I'm like.
Yeah.
I thought my doctor, I could have someone, she told me that my pills are progesterone only.
Yeah, there are. I was just about to say, some pills are progesterone only.
And that's why you shouldn't smoke.
I'm confused.
Say, what is smoking?
What is smoking? I don't get it.
I
think the world thinks you have problems.
Like blood clot. I'm assuming like blood clot.
Yeah, I don't think you're supposed to smoke on any drugs.
You must smoke anyway, Peter.
I know. Yeah, have y'all, I mean,
I've been so sick like that. I ain't never thought about it like that, but if that's what I've been going through, like these scales and.
it's called a cigarette.
Just a cigarette.
Yeah, I did, nothing else, it's a cigarette.
I hate to say this, but actually somebody dropped some Marlboro cigarettes.
It was nobody in this class, nobody in this class.
No,
Yes,
I think
I
it
did.
was really, nothing yours.
It was like a couple
You
weeks
were at
ago.
that.
Yeah, it was a couple weeks ago.
We
And it's been-
They were,
We think they were Brooks.
no, they weren't, they were.
They were
They were Emily.
I do too, you were at that.
They were
Marlboro
Emily.
Ultra Light for things.
They were light.
It was you.
Thursday, okay.
Cause they're behind the, what you call it?
kind
You
of
just said this.
I mean, there's.
Because I've tried them.
I know, right?
Because you tried.
It's usually
No, not really.
Look
I
at
don't know.
It's pretty.
I started on light and went to midnight.
Mine is smoking right
You
now.
are?
I just started on them.
It's not me, I
think.
can't, I don't smoke, but I started.
Well, how do you get started? You ask a friend to smoke one?
I've been smoking.
I know they
It was peer pressure.
That's what I started from.
So much. I was gonna have.
Yep, and you see somebody that you ask.
I've always
for
lived
something,
like that.
and then you just not smoke all the time.
I grew up in a non-smoking
That's the
home,
way it
that's why I
is.
wanted to try it. They were like, no, don't do that.
Exactly.
You've been a long way.
I don't know.
There's that girl. Alright, where are we?
Luteal phase deficiency. And that can be associated with infertility and early pregnancy loss if you do manage to get pregnant. Alright, other things that can make the endometrium appear irregular or more ectogenic are submucosal fibroids, which are the ones that push and impinge onto the endometrium, polyps, and adhesions. Saline infusion, sonography. Sonography. No, I just, oh my gosh. Sonography can be used in these situations to further delineate the anatomic structure of the endometrium. And this is where they shoot that saline in the endometrium and open it up, and you can see the polyps, or you can see
That don't sound like it feels good, really.
it can be uncomfortable some doctors do an endometrial biopsy at the same time, like Dr. Sharp at Sharp and Stone. He always does an endometrial biopsy when he does one of those, and like those patients will about come up off the bed when he does it. He's like, all right, big finish, and they're like screaming
My
in
sister
their
laughed
daughter.
for a week after she had done
Yeah.
it. That is horrible. And she got in
I don't think
regular.
I want to get past it, I don't know.
And it like shoots this needle and it like
Are you nervous every time?
No, what's that?
You gotta give me a sedative or some of that. That was
Right.
wrong.
cigarette.
Yeah.
Be on the table.
I know, I was supposed to go like a
What
week
was
ago
that?
and cancel it.
What do you need to? It's important.
I don't
We've been having Thanksgiving, so I couldn't have any.
We're not there yet. Okay.
Why can't you just pick something from every page, so I don't have to worry
They
about it?
have people on my page.
I know, it's like,
I thought I was helping you guys out by not making it every single page. Besides, half the time I highlight up in yellow.
Oh, no, don't stop.
Look, she's
Yeah, I agree.
Chill, Jessica, chill. Okay. Fibroids and polyps can potentially impede implantation. If the zygote tries to implant wherever on a polyp, it's just not gonna work. And therefore, if found, they can be removed to enhance fertility. The polyps can be removed, fibroids can be removed, and hopefully that will usually help decrease the infertility factor. Syncay are typically seen on ultrasound as linear strands of tissue extending from one wall of the uterine cavity to the other. We've already talked about Syncay before. Here in figure 44.9, that's showing one. This is actually while someone is having the sonohystogram there. But that's a Syncay, and I think I put another. Okay. Well, here are just some more. So here's just the submucosal fibroids. See how the endometrium goes up and they're like hooked tremendously. That's gonna be hard to get pregnant with that. Alright, so here's a polyp. This is another issue causing fertility. And the thing about polyps is that they have a single artery that feeds them. So they have like their own little vascular pedicle, and this is it here. Kind of cool, right?
what if you have one?
Not if you have one. Okay, and here's a uterine Syncay. So this is, I mean, they can cause issues with pregnancy, but then pregnancies can happen just fine with them. And those are usually caused due to, some kind of uterine trauma during like surgery, or maybe I knew this lady, she was in a bad car accident, her seatbelt caught her right here and it kind of messed up all her uterus and all that stuff. So I think she ended up having to have a hysterectomy instead of just having a Syncay, but I mean, could be cool. Okay. So evaluating the fallopian tubes. The fallopian tubes can be examined by ultrasound for hydrosalpinx and to assess patency. What is hydrosalpinx?
Fluid in the fallopian tube.
Okay, good.
Yeah, it
Well, you should have known from the quiz
Well, I
and
did,
the
that
last
was from
week
last
too.
week.
Yeah.
It's old news.
But it's here right there. It's like, go away like cold. Alright, do what?
I don't think it goes away.
No, it's repeating. Because you need to know it. Alright, a hydrosalpinx is a fallopian tube containing fluid. On ultrasound, this appears as multiple cystic tubular structures in the adnexa. Let's see, hydrosalpinx is associated with a 50% reduction in pregnancy rate. And then removal and drainage, a removal of such damaged tubes can dramatically improve in vitro fertilization success. So, if you have one of your tubes taken away, if you ovulate from that ovary, it's not going to make it to the uterus. So, you may have to do the IVF, which we'll talk about in a little bit. And so if you don't have like the hydrosalpinx there, then it can increase that. But here is a hydrosalpinx. So here's a fluid-filled tube, fallopian tube. And just evaluating the ovaries. During the ovarian follicular phase, which is the first phase, once we're starting back over, there are several antral follicles on the ovary that are less than 5 millimeters in diameter. A follicle is selected to develop into a dominant follicle in response to follicle-stimulating hormone, which is the FSH. What secretes FSH? Yes, the pituitary gland. What triggers the pituitary gland to secrete FSH? What hormone by the hypothalamus is secreted that triggers it? No, LH is also secreted by the pituitary gland.
G and
Estrogen is secreted by the follicles.
G and H, G,
Yeah, you got it.
Yeah,
Gonadotropin-stimulating hormone.
GC or
That's it. Okay. The dominant follicle will grow at a rate of 1 to 3 millimeters per day until it reaches an average diameter of 22 millimeters. I think in another chapter it says 24 millimeters. Just somewhere between 2 and 2.5 centimeters, or 20 and 25 millimeters. It's going to differ, but just know in that area. And once that mean diameter is reached, the dominant follicle will rupture, and then the egg will be released in the fimbriae, and the infundibular portion of the fallopian tube will bring it in, and then it will go through the fallopian tube. What portion of the fallopian tube is fertilization usually occur in? Ampulla. All right.
On 1043.
Alright, sonographic findings associated with ovulation are echoes within the fluid left behind, which is the corpus luteum cyst, or free fluid in the peritoneal cavity. After ovulation, it is common to see free fluid in the posterior cul-de-sac.
Okay, yeah, I lost you there.
After rupture.
Okay, I was thinking.
In the middle of that first paragraph from the picture.
It's the sentence that I have up here.
I was busy with my
That
sheet. Which one?
All of them.
All of them. Well, I already got all of them.
Basically, that whole thing, evaluating the.
Well, if y'all quit checking what you got from Victoria's Secret. Listen, with all the
I wasn't checking, I was just thinking out loud.
You don't call me out.
You know, when you spend your money, you wanna know where it is.
All right, moving on to the next paragraph. All right, one condition that can inhibit the release of FSH and LH is polycystic ovary syndrome or ovarian syndrome, and we talked about that last week, and y'all know all there is to know about PCOS, right? Mm-hmm. Or not last week, but the week before, but y'all took a test on it, so you should know about PCOS. Okay, so we could just skip this entire section, and y'all would still know it. All right.
But just for the fun of it.
Or we could keep it on the
Since
test.
we're here.
Yeah, that's right here. Let's just go over. Okay, this is really quick too, but PCOS often occurs with the diagnostic triad of oligoovulation. So that's either no ovulation, which is anovulate, whatever. And then the oligo is you don't ovulate every month like you're supposed to. So you're ovulating less, maybe every like 4 months or something. And then hyperandrogenism, where you get too much androgen. Remember, your body, everybody has estrogen and androgen in them. It just, people get converted, yes. And so if there's an issue with the ovaries, some of that androgen won't be converted. You'll just have too much androgen in your body. And you get all hairy, and you get all manly sounding, and, yeah. And then, of course, you'll have the polycystic ovary. with PCOS, follicles begin to grow but do not develop normally. Whenever you see a polycystic ovaries, they're usually all very small follicles. You don't ever see like really big cysts. You may occasionally, but for the most part, they're going to be a little tiny little cysts around the periphery of the ovary. Or there may be so many that it will just take up the entire ovary. And in this syndrome, the immature follicles continue to produce estrogen and androgen. This production inhibits the pituitary gland's function and prevents normal ovulation. This is due to the pituitary gland producing more LH than FSH, which causes the follicles to remain in an arrested state of development. And so no mature ova actually forms, or no mature follicle forms, and causes the ova to be dispersed or rupture out and get to the fallopian tube and all that. Women with PCOS may also present with irregular bleeding and a thickened endometrium as a result of the chronic elevation of estrogen. What?
What you're saying? Or did you?
Okay, now you gotta go to the next.
Sorry, guys. Is this on the paper?
Yeah, I just have to read it. Let me.
You don't want me highlighting for me.
I might as well try the whole page.
It is a paragraph, Jessica.
Balake.
Okay.
Key and Peele.
That's what I thought. That's what I think she's doing that from. Are you not doing that from Key and
Key and
Peele?
Peele? Yeah. Oh, all right, Hey, everyone. Hey, coffee.
Larry.
La la.
Oh, that's it.
L-R-E.
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 L-R-E. L-R-E. All right. Everybody got this one? All right, so evaluating the ovaries, the sonographic findings for PCOS. Typically represents as a rounded ovary with multiple small immature follicles in the periphery. Again, this is that string of pearls sign that we'll see. And the follicles are usually pretty small, about 2 to 9 millimeters. They don't even make it to, 1 centimeter, much less the 2 to 2.5. That immature follicle usually measures right before ovulation. Yes.
Nothing.
Johnny, okay.
No.
Good talk. Okay, so here's our other picture. I skipped the funny pictures. Overreact.
Yeah, it's hilarious.
That's so funny. Okay, so here's the polycystic ovary. String of pearls. Okay, I just cut y'all short on the polycystic ovary. Okay, it may be peritoneal factors, alright? Just highlight first 1, 2, 3, 4, 5, 6, 7, 8, 9 line over. Yeah, that's all that's right here. So the peritoneal factors may be the cause for as many as 25% of infertility cases. And the peritoneal factors are adhesions and endometriosis. And adhesions are bands of scar tissue that can obstruct the fibroated end of the fallopian tube. And then sometimes fluid will collect in between adhesions and result in the peritoneal occlusion cyst. You guys know about peritoneal occlusion cysts, right? Because these aren't like true cysts. These are just this fluid collected and kind of stuck in this area due to these adhesions. That's usually due to some kind of like pelvic trauma, because it's scar tissue. If someone's had pelvic surgery, the scar tissue can form make these adhesions here. And then endometriosis is caused by the ectopic placement of endometrial tissue outside the uterus. Ovaries is the most common location. What is focal endometriosis called? was on your quiz.
Endometritis.
What? Endometrioma. Endometriitis, itis is the inflammation. Inflammation, that's the infection. Endometrioma is a focal form of endometriosis. What is like internal endometriosis, where it's just in the uterus? What? No, that's infection or inflammation. What is it?
Adenomyosis.
Adenomyosis. Yes. That's typically it's in older women that have had pelvic surgery and due to some kind of, I don't know, laceration or something or another, the endometrial tissue is able to get into the myometrial tissue. Yeah, I mean, they can have laceration. Well, I mean, you know, what if you had an IUD perforate, or you could have got mugged at Walmart on Black Friday, someone stabbed you over a tablet or a steamer. I don't know what those steamers were. Just in that video where that woman's like, look at it. I think that was a steamer. I'm like, what the heck you need a steamer for?
They said on the radio this morning they got video on the stage.
I thought so, because there were so many steamers all over the floor, and they were like, why would you not just get one on the floor? That's what I was thinking too. I was like, that's fake. But, anyway, ovarian induction therapy. This refers to a treatment in which ovarian stimulation is achieved in a controlled setting.
Can you change?
Yeah, I can.
We don't wanna see it.
Here's a peritoneal occlusion instead. I'm going to show you another one, and it's got the adhesion pointed out for you. Turn the lights off. Just make y'all look at it. The uterus, adhesion. This is a peritoneal occlusion. Treatment options.
Oh my Lord.
Alright, and so whenever someone starts to have this done, they'll have a baseline ultrasound that's done. You gotta measure the ovaries really well, the uterus really well, endometrium, and then you gotta measure like every single follicle on the ovaries. I had a patient that I had to do this with, and the patient was like the local pediatrician's wife, so I was like, dang, so I gotta be like really good at this. And she had so many follicles. It was like 23 or 25 on everything on both ovaries. She was coming in once a week. I mean, sweet as can be, but God. I was like, it's so many ovaries. Or so many follicles. It felt like so many ovaries. Like my arm was like go numb, my shoulder was also, oh my God. But anyway, you gotta do your baseline ultrasound, and then they'll start taking the medicine. Usually it's Clavin, or that they take to help make the ovaries just like work better or start to overreact. And alright, and then once the therapy is started, you gotta monitor the number inside the follicles in days 8 to 14, which is that follicular phase. That's right before ovulation. So that's when you want to know, is the follicle large enough to produce a mature ovum? And so that's when you're going to want to check, is right before ovulation. Okay. You are going to want to measure. Hang on, sorry guys, I'm sorry, it's all messed up. So ultrasound is used for monitoring. You're going to want to count and measure all follicles greater than 1 centimeter. However, they told me I had to measure every single one of them. So it just depends on where you are. Some places, like the book says 1 centimeter, they told me I had to measure every single one of them. Probably because it was the pediatrician's wife, so I had to overachieve for the doctor. Okay. Anyway, optimal mean measurements of a mature follicle is between 16 and 20 millimeters. But again, you know, it can be up to 2.5 millimeters. But as long as it's in that area, they told me, that we were always looking for one that was 23 millimeters in measurement, and that's what, and that doctor, what she was using. So she's like, tell me, I want you to measure all of them, so that, and I need to know how many follicles are measuring 23 millimeters or more. Okay. So, alright, so correct measurement of follicles are very important because you get the HCG, which is a substitute for LH, may need to be given intramuscularly to trigger ovulation. So if they're not ovulating, you can get that a needle shot in your muscle. I don't know what muscle they were sticking that in. Probably your butt cheek, I don't know. But, and that can help trigger ovulation. Alright.
Well, they're giving death over in stolen
Really?
I know that was random, but we were talking about it with her.
Yeah, I don't know.
See, they made me get mine in my hip and it has to rotate each time I go.
Well, that's how mine was, and the last time I went, they said there's something to do with my stomach. Yeah, well, I'm getting on people.
Okay, well, I went to ultrasound, I was in the program with Diamond Hair, with a student, and she had dimples in her arm, but she quit because she said they made her arms fat.
It don't just make your arm fat, it makes your whole body.
I never heard anyone with their arms. It's sort of what she said.
Yeah, I weigh arms fat. I got death over, I got up to about 140.
Oh my God, how dare you weigh 140? Okay, so here is some ovaries that are like hyperstimulated. Yeah, these are pretty stimulated. Okay, let's just go next. Monitoring the endometrium, just highlight that second sentence. A normal endometrial response associated with ovarian stimulation is increasing thickness from 2 to 3 millimeters to 12 to 14 millimeters. So whenever the ovaries are stimulated due to, this Clomid or HG, whatever it is they're taking, it's going to go up to the upper limits of normal. So remember the normal endometrium is supposed to measure less than 14 millimeters in a menarcheal female. What is it in a premenopausal? In a menopausal?
Less than 5.
Yes. That is correct. Good job. Alright, in vitro fertilization is a method of fertilizing the human oocyte outside the body. Does anyone know what it's called when you do it inside? I know they're calling it intrauterine insemination, but there's another. Yeah.
Wouldn't it just be artificial?
It's here, but I was looking for you guys to also say in vivo. Maybe they don't call it that anymore.
I've never heard of that.
In vivo?
I've never heard that thing.
I never heard of that.
Because you had because I remember trying to learn the difference between in vitro and in vivo, and it was so aggravating because I could never get them separated. But anyway, mature oocytes are collected and mixed in a dish with a sample of sperm. The resulting embryos are then placed back into the uterus. So this is where fertilization occurs outside of the body. It's done in a little sample dish or mixing dish. And then the embryos are put back into the uterus. Alright, intrauterine insemination. Oh, this is not in the book. In this book, it was in the last book. It was in the 6th edition, or last one, this one, because it was on my registry. The oocytes are retrieved laparoscopically.
That's why you put that on that paper so I couldn't finish.
Yeah.
Yeah.
They are fertilizing the dish.
Well, also I'll put it on the paper because it's a good chance it might be on your test, and also it was going to be on your OB/GYN registry, I'm sure. Because I kept telling them, I was like, oh, this was on there, and every time someone took their OB and came back, they're like, yeah, that was on there.
You remember so much stuff that was on that thing. Yeah.
Taking a bunch.
Oh.
I know, I failed it 5 times for a long time.
Can you just write it down for us?
Every
Yours,
time she
so
says
we can
something
study
in the
from
book,
it?
I
Probably
That's
doesn't remember
the
until she sees it.
That's what I'm saying, it's got like that.
Yeah, I have a paper. With the OBGYN. I usually do right before you come in.
Did you guys follow them the first time?
Of course you did.
Except when, I went to take my vascular, they had just changed the thing, and, my name didn't match. So I had to pay again, go back and take Astromed. They just changed it, and they're like, if your license doesn't match what we have you registered at, they had me as Carrie A. Crim, so my license said Carrie Ann Crim, and so they're like, it doesn't match.
Oh my
But
So
so
you
I
had to
looked
pay
crazy
twice?
on that lady.
Why did you pay if you didn't take it?
Because he forfeited. Like, if you don't take it at this time, even if you like get into, I mean, maybe you can, if you get like into a car accident or something on your way there, maybe you can call RDMS and be like, okay, here's my police report, I broke my leg, you know, can I please have my money back? Or just refund it to me or something. Then I guess you can do that. But no. I know, that's $200.
So how long before like we graduate, when we can, what's that time when, before we can take the?
A week. What?
What's the timeline before we have to take it?
You're gonna take your physics.
Right, first.
No, but like
In your
after
lab.
graduation, how long do you have to complete?
That the
registry
school
is
will
what
pay
it's
for it.
asking.
Oh, no, you can take, for the college to pay for it? I don't know. They go ahead and pay for them though and set them up. So if you don't take them at those 2 times, I don't know.
Which one would you take first?
The OBGYN is the easiest. So,
You get job placement and then you can take the other one.
yeah, so once you get that RDMS, then it's good. But, you know, the abdomen to me was the hardest, but however, vascular seems to have the lowest pass rate. And then, you know, in 2017, you have to have your RVT to do vascular. So you really want to get all of them. But just to get registered, go ahead and get your name registered at OBGYN is usually.
But what do you do, okay, so you get all of them, don't you have to keep them up for a certain amount of time and then have to retake it if you don't?
What?
Like,
Oh,
like certification in a way, so you have to renew them.
you have to pay a yearly fee. It's $75. Doesn't matter how many registries you have, it's $75. You gotta pay yearly. You gotta keep your receipt because you can have it for taxes. And then, you gotta do CME. That's continuing medical education. And you have to get 30 every 3 years. And whenever you pass the registry, you actually get 15. So. And then you can do all types of things. Those sauna worlds, have y'all done those yet? Okay, those, they have CME credits. Books, you can get books that have credit. There's, you can go to like seminars, they have credits, you know, conferences and stuff, they have credits, stuff like that. Okay, let's at least try to finish this chapter.
Yeah.
Okay, we're almost done. Okay. Artificial insemination, that's a technique used to treat male factor infertility. And this is when there is intrauterine insemination. Sperm preparation may be from a donor and referred to as artificial insemination using a donor sperm. Alright, and then complications associated with all of this, assisted reproductive technology or ART. When I was on my clinicals at Sharp and Stone, we saw a lot of like ART patients. They were in the ART program, and I guess they just like to send them there. So we saw a lot of these patients. And different ones have different complications. You have multiple gestations, ectopic pregnancies. But with ovarian hyperstimulation syndrome, it can present sonographically. You can get enlarged ovaries. You know, we talked about this. We talked about pathology of the ovaries. And there can be multiple cysts. You can have the abdominal ascites and pleural effusions. What is that triad of things called right here? What syndrome? Meg Central. Yeah, good job, Jessica. All right, moving down to the next paragraph. Patients who undergo in vitro are at increased risk for having multiple gestations. You okay, Jaleesa?
Mm-hmm.
Okay. I need a camera so I can take some pictures of me now. All right, there's an estimated about 30% of in vitro fertilization pregnancies result in multiple gestations. That's a pretty high number. And you know, I was in this program with someone that had that done, and she ended up with 6 babies. 7 actually, but one of them had died in utero.
Jesus.
When you think of that many, you think of a dog having that many babies. She had them all?
That was.
She had them all. She had them all. And then she got her own reality show. Yeah, well, y'all got quiet. She got rich. She got her house makeover by Extreme House Makeover, Extreme Home Makeover, whatever. And then she got her own reality show on Discovery Health.
Is she married?
Mercedes.
Look at the there talking about she married.
Yeah, she doesn't tell.
I knew it was something like that,
Yeah.
like Mercedes.
Yeah, they come here to school and like film.
So she didn't finish the program. She's been doing this one.
She was.
I remember, cause
But you don't need it now.
Okay. Alright. That reminds me of Parker. He goes, stop it. Whenever he thinks like we're wrestling or something, or he thinks we're getting in a fight, he'll go, stop it. He'll say it really hard. Stop it. Alright. Concerned with multiple gestations, that there are 3 or more fetuses, there's an increased risk for fetal or even neonatal morbidity and mortality. So they can either die in utero, or they can be born or have complications and then die afterwards. So fetal reduction may be performed, and I saw that too, broke my little heart. Oh my God. There was someone that had this done, and they were pregnant with 5, and they had 3 of them killed, and so they only had 2. They had twins after that, and so we had to.
you helped with that?
I did not help with that. No. I was in there for the ultrasound afterwards, like I think like a week after or something. All right.
Right in the hallway.
No, I didn't. I'm kind of wearing a beater or something, but I know that's hard. I don't know what. I mean, I wasn't in that situation. All right. Patients who undergo assisted reproductive technologies are at increased risk for ectopic pregnancy. Ectopic pregnancy is when there's a pregnancy outside of the uterus, right? Where is the most common location for an ectopic pregnancy? Yes, fallopian tube. Patients also at risk for having a heterotopic pregnancy. You guys remember this from last week, right? That's where you have an ectopic pregnancy coexisting with the intrauterine pregnancy. Remember I showed you the picture of having the IUP, which is an intrauterine pregnancy, and then you have the ectopic out in the fallopian tube. And the end. Alright, so now let's start on the breast chapter. I'm just kidding, I'm just kidding. We'll just do the breast next week. So make sure that you bring your book, volume 1 next week, guys. Don't tell me you didn't hear me say it. And also, it's on the syllabus of the breast chapter 1, Just show it to me, and then I'll